Hi everyone, it's Tara. Here on Primary Focus, you've probably noticed that we're taking a bit of a summer production break. But we're working on some great new episodes for the fall. And in the meantime, I wanted to share this conversation I had with Dr. Anton Helman and Dr. Danielle Martin on a topic we haven't really covered on Primary Focus: the intersection between primary care and emergency room care. Anton is an emergency medicine physician in Toronto, and he's also a podcaster. And this conversation was actually recorded for his podcast, Emergency Medicine Cases, or EM Cases. As you'll see, it's a far-reaching discussion tackling a range of topics. Is the primary care access problem the cause for emergency department overcrowding? Do emergency rooms have to be the safety net in our system? Or is there another way? And how can primary care and emergency medicine better collaborate? We're going to play you a few excerpts from our conversation, but if you want to listen to the whole thing, head to the show notes for a link to the full episode, available at emergencycases.com. And just a note that this podcast was recorded back in October 2025, which was before our friend of the podcast, Dr. Danielle Martin, became a member of Parliament in the federal riding of University-Rosedale in Toronto. If you want to hear more from Danielle, head to our first ever episodes, which we've linked in the show notes. I hope you enjoy the conversation, and happy summer.
EM Cases is brought to you by SHREMI, the Schwartz-Reisman Emergency Medicine Institute. That's a nonprofit organization dedicated to improving EM care through high-quality research and education. The opinions expressed on this podcast are intended for information and education purposes only and should not be used to diagnose, treat, or prevent any medical condition, nor should they be used as a substitute for medical advice from a qualified practicing physician. In 2017, almost a decade ago, I attended the fantastic SMAC conference in Dublin. One of the really thought-provoking debates for me was titled, "Is Emergency Medicine a Failed Paradigm?" with Scott Weingart arguing that it was a failed paradigm. Scott eloquently explained that the system is forced to serve both critically ill patients and those with less urgent needs, which creates a mismatch between the skills required and the actual day-to-day work, and this leads to cognitive dissonance and burnout. Simon Carley, on the other hand, countered that EM's ability to adapt to the increasing demand on EDs is our strength and not a failure. He argued that adaptability is our superpower, that the core purpose of EM is to provide care for anyone who presents to the ED when they feel they need it, that we're a safety net for the healthcare system, and the generalist approach is crucial for triaging and treating a wide variety of conditions and uncertainties. And we're really good at this. They proposed a variety of potential solutions for the so-called failed paradigm. Essentially, it was either narrowing the specialty to focus solely on resuscitation and acute critical care, or train doctors to handle the full scope of ED care, or restructure the system to separate the critically ill from others. And I remember at the time siding with Simon Carley on that debate, feeling very proud to be an ED doc and that I could handle anything that comes through the door, increasingly honing a wide skill set, embracing lifelong learning. I love the idea of an outward-facing ED, a sort of modern-day secular sanctuary, in the words of my mentor, Howard Ovens, who's been on the podcast many times. You know, a safe place to turn for care and comfort when nothing else is available. But now, almost a decade later, I feel myself agreeing with both Simon Carley and Scott Weingart, because I think I can safely say that all of us in emergency medicine feel super frustrated and overwhelmed by the massive volume of patients we need to care for who have fallen through the cracks of our healthcare system, but we don't have the resources, knowledge, or time to care for them properly in the ED. It's gotten to be too much. And as Weingart predicted, the current situation I've described is probably at least partly responsible for the 25% attrition rate in emergency medicine in the US and the 20% attrition rate in Canada since the pandemic started. Now, this is where primary care comes in and our relationship to primary care comes in. Emergency medicine and primary care are two specialties that serve the same patients but often live in different worlds. In one, you've got longitudinal relationships, continuity, and prevention. In the other, you've got rapid diagnostics, resuscitation, and a revolving door of undifferentiated complaints. But here's the reality. Our patients don't live in silos. They come back and forth between their primary care physician and the ED, and whether they fall through the cracks or get the care they deserve depends on how well we, primary care and emergency medicine, work together. Today, we're going to unpack the tensions, explore the pathways, and highlight solutions that primary care and EM can own together. How do we triage, communicate, and share data better? What funding models make sense? And most importantly, how do we build relationships that serve patients across both acute and chronic care needs? So there'll be no turf wars today, just collaborative conversation about making the system actually work for people it's supposed to serve. We'll define what right care, right place means in this context, learn from global models, and drive home 5 concrete action items you can do this month to tighten your ED primary care pathways for better, less frustrating care, no matter where you practice medicine. And to help us do this, we've got 2 very special guests on EM Cases, Dr. Tara Kiran, a family physician and researcher who's passionate about building a stronger, more equitable primary care system in Canada. She practices at St. Michael's Hospital, Unity Health in Toronto, where she's also a scientist at the MAP Center for Urban Health Solutions. In 2022, Dr. Kiran launched Our Care, a national initiative to engage the public in shaping the future of primary care in Canada. And she's a fellow podcaster. She's the host of the fantastic podcast Primary Focus. Dr. Danielle Martin is the chair of the Department of Family and Community Medicine at the University of Toronto and a practicing family physician at Women's College Hospital. She's a founder of Canadian Doctors for Medicare, bringing a national lens to equity and access in primary care, and she's the author of Better Now, 6 Ideas to Improve Healthcare for All Canadians. Previously the executive vice president and lead medical executive at Women's College Hospital, Dr. Martin helped launch Canada's first virtual hospital. Welcome to EM Cases, Dr. Kiran, and welcome, Dr. Martin.
Thank you. It's great to be here.
All right. Let's start off with some myths and misperceptions about how EM and primary care operate in our healthcare systems. What we'll do is we'll start off taking turns alternating between the 2 of you on, let's say, your top 3 myths and misperceptions about the best way to provide primary and emergency care to patients. And then we'll dig deeper into each of those things as we go through the podcast. So let's start with you, Dr. Martin.
Well, one of the myths that I grapple with as a primary care clinician is the myth that the reason that emergency departments are crowded is because too many people are showing up with problems that could have been dealt with in primary care. Now, of course, we know that there are people who come to the emergency department with issues that could have been dealt with in primary care, and they come for all kinds of reasons, sometimes because they couldn't get in to see their team, sometimes because they couldn't get in at a time that was most convenient to them, sometimes because they're scared and worried about something that you and I might not find scary or worrisome. But none of those things is what causes crowding in the emergency department. In almost every developed country in the world, emergency departments are crowded because they are full of patients who are waiting for a bed upstairs. And they're waiting for a bed upstairs because it's hard to discharge people who are ready to leave the hospital. And we can't get enough access to other resources in the community. And so that blockage in the system is not the result of the twisted ankle or the sore throat that's landed in the emergency department. It's a system level problem. And I hate it when it gets laid at the feet of patients with what we perceive to be non-emergency problems coming to the emergency department.
Yeah, absolutely. We did a very long, deep, complicated podcast on overcrowding and access block. And in the title was Access Block, which is exactly what you're describing, is that access block is the key determinant of ED overcrowding, not people who have minor problems coming to the door.
Yeah, maybe I'd just build on what Danielle said, because I think this really came to light in a way that was really terrible for actually a lot of family doctors during the pandemic. We had media, senior health leaders, people in government who basically said the reason that emergency rooms were crowded was because too many family doctors were seeing patients virtually. Their offices weren't open enough to in-person care. And, this even got to the point in our jurisdiction in Ontario where the chief medical officer of health, along with others, issued a statement saying, like, you need to basically see more people in person, family doctors. And, in fairness, actually, the government did ask us as researchers to take a look at the data to see, is this narrative out there actually based in fact? So when we looked at the data, one of the things that was really interesting to see is that, first of all, actually, emergency department volumes actually weren't at pre-pandemic levels during the first 3 years following the pandemic. And so the issue for emergency department overcrowding wasn't actually that there were more visits to the emerge, because there weren't any more visits than there were previously. Instead, I think there were issues, as we've talked about, with staff shortages and, all the things you've probably talked about in your podcast on access block. But what we also found is that, family doctors were seeing lots of patients, both virtually and in person. And in fact, when there were high numbers of COVID cases, there was a lot more virtual care being provided by family doctors. And at the same time, the volumes in the emergency departments were actually lower. And that makes sense because we told people when COVID cases were high, don't go in if you don't need to. And so instead, though, I think the reason I bring this up is because I think it, also illustrates that people are very quick to blame family doctors sometimes for health system problems without looking at the data in detail to see, is this actually borne out in truth?
We got some hard data there that disproves what most emergency physicians believe, I would guess, and that is a great first myth. Let's go with a second myth or misperception.
All right, maybe I'll kick us off here just to say that we're in a situation specifically here in Canada where too many people don't have access to primary care. So some of the data that we collected through our care suggests that it's more than 6.5 million people in Canada don't have access to a family doctor or nurse practitioner that they can see regularly.
Okay, and for those of you listeners who are from other countries, the population of Canada is about 40 million. So 6 million of those people don't have access to primary care.
Yeah, so it's about more than 1 in 5.
And this is a problem not just in Canada, but in many countries. Some have worse statistics than that, some have better. But I think medical professionals from other countries see Canada as this amazing place that provides amazing care to everyone. And it's actually a bit surprising to know that 6 million Canadians don't have access to primary care.
Yeah, it's really terrible. And we can talk more about the implications there. But I think one of the things that you hear is that, if we get everybody access to primary care, that's going to mean emergency department visits go down. And it's true that supporting people to be healthier over a long term is going to mean less use of other parts of the healthcare system. But at the same time, we're not going to necessarily see an immediate effect on emergency department visits. There have been some really interesting studies, like in the US, where people got access to primary care. And after getting access to primary care, actually there was an increase in emergency department use because people actually had a lot of unmet health needs for many years. And when they started to get access to primary care, those unmet health needs were uncovered. And sometimes family doctors were like, actually, no, you need to go to the emergency department and get care. And so I think we have to be careful when we're thinking about what are the reasons why we're investing in primary care and how are we measuring success. I worry when governments look to measure success in primary care by just looking at emergency department visits.
And if I could just add to that, because I completely agree, I think that, the inverse is also true, that having access to a family doctor, a GP, a nurse practitioner, a primary care team may or may not reduce the likelihood that you show up in the emergency department with the proverbial sore throat or twisted ankle. And I don't think we should worry too much about that, to be honest. What we know it will do is, over the next 10 years, make you less likely to have a stroke because we will help you to control your hypertension and your diabetes. It will make you less likely to get readmitted to the hospital because we will help to control and manage your chronic lung disease. And so, the impact of primary care on the health of a population happens over years and decades. And I worry that the focus of policymakers very often, and sometimes of our colleagues who work in the acute parts of the healthcare system, that there's a misperception or a myth that if you have good access to primary care, you're going to stop using other parts of the healthcare system right away. And as it turns out, we may discover you need to use the health system more for a period of time, but over the course of your lifetime, your utilization will go down, your chronic diseases will be better managed, your quality of life will be better. We are in it for the long term in family medicine and primary care. That's our job in the healthcare system. And we need to help people to take a look at that longer time horizon when they're assessing, for example, what is the return on investment in opening up a new primary care team or graduating a bunch more family doctors from your medical school or whatever the case may be.
That's a really insightful clarification. All right, we've got 2 myths and or misperceptions down. Let's do one last one because we've got lots of ground to cover in this podcast. Dr. Kiran?
So this is actually one that I was thinking about when I was listening to your introduction. And I was thinking about my own conception of how we structure care in Canada and our assumptions around how we should be structuring it in the role of the emergency department. So I think we think about emergency departments, to your point, as like that safety net, that place where anybody can go at any time and they will always be able to get care. And that's a lovely thing in many ways, but we've talked about some of the tensions there. You've talked about some of those tensions. And so in some ways, I feel like the myth maybe is like that is the part of the healthcare system that is like the open door. Can we think about another part of the healthcare system or as the open door? Can we think about a primary care system that is the open door for many, with the emergency department being there next to and supporting that primary care system, as opposed to the emergency department being the one open door? And I've started to, my own thinking around this, I think, has been challenged partly through my visits in countries like Denmark and the Netherlands, and we'll talk a little bit more about that. But in those countries, family doctors are the front door for everyone. Everyone has a GP, and you actually can't go to the emergency department unless you see a GP first. And, we can talk about how they structure it to be that way, but it means that, no, not everything is coming to the emergency room. And that emergency room doctor is not dealing with all sorts of non-urgent issues. And so I think that we've structured our system in a certain way, and it worked for us for many years, and it's no longer working for us. And so I think the myth here might be just that, the emergency department as it's structured is the way it has to be. And I don't think that that's the case.
Yeah, we're really going to have to think about overhauling a lot of stuff.
Yeah.
So with overhauling a lot of stuff in mind, I think we should dig into some specific solutions and dig into a little bit deeper about exactly why all these problems are happening. So let's start with how to reduce avoidable ED use. Again, this doesn't contribute in a significant way to overcrowding, but it is something that we do want to strive for the patient's benefit, right? So if you could flip a single system lever tomorrow to reduce avoidable ED use without harming access and ensuring continuity of care, what would that be? Dr. Martin?
I think it would be a rational, neighborhood-based approach to same-day care for people who feel they need it. And that can be structured in any number of ways. In other words, no one expects the individual GP or family physician or team to work 24 hours a day, 7 days a week. But to the point that Tara was making about, we've imagined that the emergency department is the place that's always open and the door that's always open for everybody. What if there were another door that was always open? And what if that door, it could start with a phone line, it could start with an online tool, it could start with a well-constructed public chatbot option, it could start with, any number of different interfaces that would support an individual who feels they have an urgent issue to either take care of themselves or to see their family doctor or team the next day and give them an appointment to do that, or to speak on the phone live with a qualified clinician, or to be seen in person by a member of the team who has access to their chart and has the capacity to communicate back to that person's regular team. Or if necessary, a direction to go to the emergency department. But I think it's about having a comprehensive strategy that begins with a person saying, I don't feel well, I think I might need to be seen today, and having clarity about where to go first that allows for the possibility of new pathways being constructed. The way that I have put this, and I know this is Canadian lingo, is we have a system right now where all roads lead to the emergency department, and we need to lay down new roads to other locations through a single door.
Love it. So basically a rational, comprehensive, neighborhood-based entry mechanism into the system. Great. And Dr. Kiran, if you could flip a single system lever tomorrow to reduce avoidable ED use without harming access and ensuring continuity of care, what would that be?
Patient and public education and empowerment. Through our care consultations, we interacted with many people across the country. And one of the things we heard over and over again with them is, when they took part in our processes or deliberative dialogues, there was a lot of education provided to them. So they spent often 30 to 40 hours with us. And a big portion of that was learning what primary care is, how the primary care system works. And they left those interactions feeling so grateful, actually, for that education. Some of them said, we thought we knew a lot about the healthcare system, and actually we didn't. And, all of the groups that came together, they all recommended that we need more patient education and public education about how the healthcare system works, and also how people can take care of themselves. Not everything needs to come to the emergency department. Not everything actually needs to be seen by a health professional at all. Somehow in Canada, and I think sometimes in other countries too, we've actually designed pathways for people, even when they have minor ailments, that they, you have a minor ailment. Okay, maybe you can't see your family doctor, see a pharmacist. Right now, for example, in Ontario, you have a red eye that you think is conjunctivitis. Most of the time it's viral and it needs no treatment. But you can go to the pharmacy now and see a pharmacist, and the pharmacist is paid for that visit, and they could give advice to the patient and tell them what over-the-counter medications they could use. But, what if we actually gave that information to the patients directly? Like actually educated them on a easy to use website, social media, really try and put forward education that supports people to manage their own health in a variety of different ways. And I will say, when I've talked to people about this idea, people also bring this back down to even our primary school and high school education. How much health literacy are we teaching our young people? Do people know what to do when they have a fever and when it is that they should be going to the emergency department? We saw this again play out during COVID. People didn't know what to do. And as it turns out, we should have been able to give people tools to self-manage and be clear on when it is that they needed to seek care, but that was often not available. So if I had to switch one system lever, it would be to educate and empower patients in the public.
Yeah, education. It's something I kind of sort of believe in myself. I want to move on to triaging. How should patients move between sort of a call first nurse/physician advice line, urgent same-day primary care, urgent care centers, and the ED without sort of ping-ponging back and forth? I understand that in the Netherlands, they use practice assistants with embedded triage algorithms who can resolve common problems like epistaxis, burns, UTIs, sore throat, minor wounds, etc. And they escalate to a primary care physician or the ED when needed. And in this Dutch model, primary care physician cooperatives and call first triage keep EDs pretty quiet. How could we make this work in North America? Like, what training, supervision ratios, and scope would we need to adopt to make it work in our practice settings?
Maybe I'll just start by going over that model in the Netherlands that you mentioned, because it is quite amazing. So the practice assistant is a role that is actually a 3-year diploma out of high school. So they're not a health professional in the way that, a nurse or a physician would be. It's actually a role very specific to primary care. So this is not that they've been trained to triage people in like a respirology setting, and then now they're coming to primary care. It's a very specific primary care training. And during that training, they're trained on triage algorithms, so what to do when people call for a whole bunch of different common things, but also actually on communication, how to communicate with patients. And the triage algorithms are actually designed in partnership with the Dutch College of GPs. The Dutch College of GPs is an organization that actually creates guidelines for GPs by GPs. And not all countries have that kind of organization. We don't in Canada. But these triage algorithms are actually all publicly available in the Netherlands. So there's a website, and the practitioners can actually look them up in real time. When they're working in an after-hours care setting, they're actually embedded within the electronic medical record. But importantly, so they use that knowledge and training as practice assistants. When people call, they help to determine, is this something that needs to be seen today? Can it be seen tomorrow? Can it be seen next week? Does it need to be seen by a doctor, a nurse? Can I myself as a practice assistant deal with it? Is it something that should be seen here in the clinic, or does the physician have to make a home visit? Or is this something actually that I as a practice assistant can resolve on my own on the phone? So an example might be a child with a fever for one day with no red flag symptoms. That could be somebody that the practice assistant can talk to the parent about on the phone and say, well, yeah, you don't need to come in right now. Here are the reasons or times when you need to. It's a very rational model. And when I saw it deployed, you see basically, in any one setting, a number of different practice assistants working with one GP kind of overseeing or supervising. They're there during the GP practice in the day, but then they're also there in those after-hours regional centers that we talked about. And in those after-hours regional centers, you might have one GP that's actually overseeing maybe 10 practice assistants who are continuously taking calls from patients. There's like one number to call from the whole region, and it comes into to their line, and different practice assistants grab that. And if there's any questions, the GP is right there, in that call center to bounce things off of. There's another GP that's there actually seeing people in person. There's another GP that's like out and doing home visits. But it's a model that works really well, and I think actually challenges us to say, well, why don't we have that kind of primary care triage here in Canada? It's not rocket science. We know what the more common reasons are for calling in. In fact, another country has done it. Can't we just bring that over right here? So I think this is something that's very doable in terms of a number of things. The approach of a virtual first approach, which is very efficient and actually very patient-centered, to this primary care triage and having a person that is actually really trained to do that job very specifically. And I would say the third piece around that is the integration into the system and the way they do that.
And what I'd add to that is, so I was recently talking with a colleague at a conference who's from a country in sub-Saharan Africa, and we were talking about primary care priorities all over the globe and how health systems everywhere are really trying to strengthen primary care, and the global human resources shortage across the whole of all health systems, but also specifically in primary care. And I said, we have all these Canadians who don't have a family doctor, and we're working so hard to try to figure out teams and everything. And he said, yeah, I know, it's hard for us too. We only have 120. And I said, 120 what? And he said, family doctors for our population of 80 million. 120 family doctors for a population of 80 million. So how do you deploy that workforce? The answer is you have community health workers in every community knocking on doors, making relationships with families, giving frontline basic health and hygiene kinds of advice, weighing babies and measuring bellies and doing that kind of a thing. And then a single physician overseeing an entire region from a primary care perspective. So I think that actually in high resource settings, which by any rational measure Canada is, although it sometimes feels like we're a low resource setting, we are not. In low resource settings, that creativity has been forced, has been there, from the outset of health system design. So just as these models exist in other high-income countries, there's also a lot we can learn from our brilliant friends and colleagues that have been inventing models in low-resource settings as well.
Great. So we've talked a little bit about after-hours care, but I want to dig into that a little bit more. The success of after-hours system seems to be not just about adding hours, but about redesigning how care is organized, how accountability is shared, and how resources are distributed. Now, before we dig into this sort of redesigning accountability and resources, first, Dr. Martin, what does after-hours care look like in Canada presently, and what does ideal after-hours care look like? In other words, what kind of care should ideally be given in after-hours primary care to maximize access and efficiency and provide the right care in the right place by the right professional?
Well, this is where we might have some healthy debate and disagreement in the podcast space, which I would be happy with. Of course, the premise of after-hours care is that a high-performing primary care system should be available to people 24 hours a day, 7 days a week. That would be the dream. And that doesn't mean that there's a person sitting in my office, doing well baby visits at 2 a.m. But it does mean that if a baby wakes up with a fever and an earache in the middle of the night, there should be something you can do as a parent other than taking your baby to the emergency department, right? So I think that's kind of understood. Where I think there is tension, which is healthy, is around this question of should all after hours coverage and care be about urgent things. I'm in clinic every Wednesday evening, and I have a group of patients who come to see me on Wednesday evenings for things that we would all agree are not remotely urgent. And most of them come because they can't come during the day. They come for diabetes checkups, they come for cervical cancer screening, they come for their depression follow-ups. And then, I also get the coughs and colds and the more kind of classic things that you would see in urgent care in family medicine. So I actually think that the dream version, and it may not be achievable in every health system all of the time, but the dream version of primary care should be that there is some element of outside banker's hours, if you will, access for things that are just routine, that acknowledge that especially people who, for reasons of the social and economic determinants of health, can't make it into the office, can't take half a day off of work, etc., can access just routine care. That may be too difficult to start with. And especially once you're into regional models and teletriage and whoever answers the phone is who deals with the issue, those things, that stuff's got to be about more urgent situations. But I do want to flag that I think the very best model would be one that we sometimes as healthcare workers, I think, sort of have a little bit of disdain culturally. I don't mean any individual person, but culturally, there's a bit of disdain for this notion of convenience. Like the patient went to the emergency department for their rash because they were offered an appointment at their family doctor's office and it wasn't at a convenient time. And so therefore they're kind of being a princess about it or whatever. Well, actually, not everybody can come in for their rash during the day. And so I just think that a really people-centered healthcare system would take that into account.
Fair enough. We see lots of that in the emerge, so why not spread that across the whole system where there's just access, weird hours?
Yeah, there's trade-offs, of course.
Really, it's just getting the access in the first place. And I would argue that whether it's for routine follow-ups or whether it's for urgent problems, I think the first step is just to get that access. So I want to talk about that a little bit. How do we actually build an after-hours care system where Dr. Martin's patients on a Friday night can go and get usual care from someone, or they have an urgent problem? How do we build that system?
Yeah, so I think let's start with where we are right now in Canada, which is not great. So, when we surveyed people across the country, this was back in 2022, it's just over a third of people said that, these are people who did have a family doctor or nurse practitioner. So just over a third of people who had a family doctor or nurse practitioner said that, that their clinic was open sometime outside of Monday to Friday, 9 to 5. So The vast majority of clinics in Canada are not providing any after-hours care. And in most jurisdictions in Canada, there's no obligation for primary care clinics to do that. In Ontario, there are some primary care models where it is part of your contract that you have to deliver that. But for most jurisdictions, that's not a thing that family doctors or primary care clinics are held accountable for. Contrast that with the Dutch model that we've been talking about, where actually part of the reason they've developed these regional after-hours centers is because historically, the doctors, the GPs, have been responsible for their patients 24/7. So that used to mean 40 years ago, 30 years ago, that they all were on call 24/7 for all their patients, which was like a huge deal. And then they figured out, actually, this is not great for us. We can provide great service to our patients and have a better work-life balance for ourselves if we come together and actually rotate coverage and cover everyone together. And so like they evolved that system to become the after-hours care that it is today. But it started with this expectation, though, that they really were responsible 24/7, and we have nothing like that here in Canada. You asked, Anton, like, how is it that we can build this kind of system here? So I think that Danielle is right. We need to think about the two different things. We need to think about ideally motivating family doctors to provide some amount of care that's regular care, ongoing care for chronic conditions, et cetera, that is outside Monday to Friday, 9 to 5. We actually heard in our dialogues with patients, people were pretty clear, like, they have jobs. It's really hard to take time off of work. And actually, if you're a newcomer and, you're in precarious work, it's really, really hard to take time off to come to a doctor Monday to Friday, 9 to 5. So yes, we need some kind of piece there. But, we also need the urgent after hours issues sort of looked at. And in Canada, most provinces and territories now have something called Health 811. So it's supposed to be like the front door. It's a phone number, but it's also a website where if people are having an issue, they're supposed to be able to call. And most of the time they get a hold of a nurse. And there are algorithms in the back end, I think, that support that nurse. But there are some key things that I think are missing there. So for the most part, the nurses don't have a doctor that they're able to turn to for advice, what the patient disposition and the advice that should be actually provided to the patient. So one of the things that's missing is nurses don't have a family doctor or other physician or nurse practitioner with more training who they can consult about advice to where the patient should go. In the Netherlands, that was actually co-located with the people taking the calls, and I think there's an advantage to that. But at the very least, even it can't be co-located, that advice should be available. And then the other important piece is that virtual triage was coupled with in-person care. So if somebody needed the in-person care, they were directed to in-person care. And, they were directed appropriately, whether that's, a family doctor in the after-hours center or whether they needed to go to the emerge or whether the family doctor went in a taxi with a driver to the patient's home. So I think we have some of the infrastructure here in Canada that we can build on. But I think we need to advance how we are delivering virtual care so that front door actually is more powerful and more accurate and can actually direct patients in the right place, and so that it's integrated also with in-person care.
All right, let's talk a little bit more about virtual care, because virtual care has changed a lot over the last few years, especially with the COVID pandemic. There was a lot more virtual care, and there's evidence that seems to be conflicting of whether it actually works or not, how it works, what the best way is. So in your view, Dr. Martin, what is the ideal use of virtual care in Canada? And once we establish that, we can talk a little bit about virtual care in other countries and how it works there.
Sure. And I'm delighted to quote Tara's research back to her. That always gives me particular joy, but also from my own experiences as a person who did a lot of work on virtual care when I was in the hospital sector. I think in summary, the evidence actually isn't that conflicting. The evidence says that when virtual care is integrated with in-person care, it is a very effective tool in most settings. And I'll park the question of the ED. I'm sure you've done podcasts about virtual ED. And if you haven't, maybe you will in the future. But I think in primary care, some of what Tara's work and others has shown is that it appears to be that when virtual care is delivered by a patient's own family physician, I'm paraphrasing the interpretation of the evidence here, that actually can be very effective, including in not reducing increased rates of emergency department use. But when virtual family medicine care is delivered to populations of patients who, by a person who does not know them and will never see them again in the one-off virtual app kind of a way, that seems to, at least under some circumstances, drive more ED use. And so that kind of stands to reason for those of us who work in primary care. You know, the shorthand of a patient calling or having a video visit with a patient you know, who you have experience of, and being able to talk through something and either give them advice and follow up with them quite soon if needed, or direct them to the most appropriate path, that relationship is a key tool. Whereas the sort of what I think of as the virtual walk-in clinic, it stands to reason to me as a clinician that since you have no capacity to see that person in person under any circumstance, tomorrow or any other day, and you have no capacity to follow them up, the likelihood that you're going to tell them they should go to the emergency department just to make sure it's not the worst possible thing is much higher. And so I think that's the first thing. And you could probably quibble with my interpretation of the evidence in some small ways, but I think that is the general direction of travel of where the evidence leads us, and certainly what makes sense to those of us who work in primary care clinically. I will say that I think the same is true when it comes to work that we've seen done around the provision of virtual primary care, where a family doctor takes on a full-on primary care longitudinal relationship with a population of patients that they may never or rarely meet in person. And there's been some interesting work done on that here in Ontario, in which you can imagine in rural communities where it can be very difficult to recruit and retain physicians, a small on-the-ground team to do the in-person stuff using a shared electronic medical record, a doctor or a nurse practitioner at a distance taking responsibility for a panel of patients over time, seems like it actually works. And it's much better, in my view, than we can't get you a permanent in-person family doctor and therefore just use an app and see whoever, whenever it is that you think you might be sick.
So what we heard from patients in the public quite clearly in our consultations is, yes, they want virtual care integrated with in-person care, but that particularly they wanted virtual care used in a way that enhances equity and access and not widens equity gaps. And one of the use cases that people talked about is, just as Danielle said, is using virtual care to enhance access in rural and remote areas. And so in one of the episodes of our podcast this season, we take listeners actually to Renfrew County, where is a great example of this happening. The story actually starts during the pandemic when, this is a rural area that's underserved, not enough family doctors, and a small population distributed over a large geography. And they needed to figure out, how are we going to be able to, have COVID testing and assessment in this type of setting? And that ended up turning into this collaboration with paramedics and largely virtual family doctors. They had family doctors often situated in different parts of the province, supporting care delivered in person, sometimes by paramedics. So if somebody, for example, had an issue in their home and they needed to be visited they could be visited by a paramedic. The paramedic could then, if they weren't able to resolve it on their own, connect with a family doctor. Or a patient, if they had questions about what to do, they could call this line and be connected with a family doctor who wasn't based in Renfrew County, because it's really hard to recruit family doctors in that setting, but actually based elsewhere in the province. And so that model has now actually evolved to actually one where they're providing ongoing primary care too, in this kind of hybrid model where there's an on-site team and there's family doctors who are working remotely. But I think it's a really great example of how we can
use virtual tools to try and address an equity gap. And in the Canadian context, one of those equity gaps really is care delivery in rural and remote areas.
Absolutely. There's a lot of VM Cases listeners that work in rural areas, and so I'm sure they'll be interested in that. So it really sounds like it is about integrated virtual care in some way, rather than just these one-offs, which seem to possibly waste money and actually drive more people to the emergency departments. I want to change gears a little bit and talk about access to patient information and data sharing. So, having efficient sharing of patient information and data is key to an efficient healthcare system, and especially important in the relationship between primary care and emergency medicine. So, Dr. Martin, what are the patient information needs to improve the system?
Well, Tara's done a lot of work on this in terms of ensuring that patients can access their own information, and I do think that that's key. I will say that in family medicine and primary care, there's kind of a Goldilocks middle ground where we need enough information to know what is happening to our patients as they travel through the healthcare system. Like it's really important that we get that discharge summary when they leave the hospital or when they've been seen in the ED, et cetera. I don't, however, need 14 chest x-ray reports from the daily chest x-ray that my patient has when they're admitted in the ICU. I just need to know when they're leaving and what happened. And so there is such a thing as too much information. And in fact, that's not really information. It's just data that is of no use to me as the primary care clinician. And so I think we want patients to be able to access their own data and they can share it with whomever they want. But we also want enough information flowing to the doctor and team in the emergency department. When my patient comes to see you, you should be able to get enough information to know, for example, what medications are they taking? What chronic conditions have they got? Why were they advised to go to the emergency department in the first place? But you don't need to know that they came to see me 3 years ago for whatever skin problem. And so you want the right and important information, and I want the same on the receiving end after they leave the ED.
Yeah, I can't help but thinking that AI could play a role in that.
Don't you think? Yeah.
Yeah.
I mean, I will say that our care was designed as an engagement for patients and the public for us to hear about, what it is that they wanted to see in a better primary care system. And what was really interesting to me is when we started to have these dialogues, one of the things we would hear again and again is about patients complaining very rightly about how it is that they didn't have access to their own records. I would say when we first conceived of our care and the kinds of things we might hear about, I actually didn't conceive that that is what we would be hearing, because I didn't always think about that as part of the primary care system. I kind of think about it as data infrastructure, maybe parts of the broader system. But it was such a consistent theme over and over again. People brought out that frustration, and they brought a lot of examples about how, maybe they went to the emergency room and they'd had a test, but that test wasn't available to them or the emergency room doctor. Or maybe they, had something really quite critical happen to them and the emergency room doctor had no idea, what medications they were on or, what had happened in a different jurisdiction or even in the same jurisdiction. And so, one of the clear recommendations coming out of our care is that patients should have access to their own record in a way that they are able to share it with other clinicians and their caregiving circle. And I do think that if we focus our attention on that, the other parts of the system connection will come. Because if patients have access to that record, they can share it. And so it can become a way for emergency room doctors and family doctors to connect with each other. We'll figure the rest out. I do think that has to be an important priority for our healthcare system. And it is one, just to contrast, one of the places I went to is Catalonia, Spain. That's a country with fewer resources than Canada. And they've had a patient-held app since 2009. And so it just, says that this isn't hard. Countries have been doing it for a long time, and we should be able to do it too. And it doesn't also have to be complete, right? So even if it is medications or labs and, key diagnostic tests, that's something. Right now, most people have nothing. One other piece that I'll put forward, when I was in Denmark, on their app, patient-held app, is actually, this medication module that is an integrated module where patients, family doctors, specialists, and pharmacists all see the same information And if a family doctor updates the medications for a patient, it is updated in real time for all of those people. The family doctor, the specialist, they can all see also the dispensing information from the pharmacist. Can you imagine the decrease in medical errors and the decrease in our own time and trying to sort out what is the true medication list for patients if we had something like that? It sounds so simple in conception, but it can have such a big impact. And to be honest, I'm not clear on why it is that we don't have something like that.
All right. We've covered a lot of ground on this episode. We've learned that patients don't live in silos, that the divide between primary care and the ED is really kind of an artificial one, that seamless care depends on communication, not turf, that after-hours care and virtual care is a bridge but not a bypass that can reduce unnecessary ED visits if it's done right, that we need the right care in the right place at the right time, and that relationships drive systems, that collaboration and building trust between EM and primary care teams turns fragmented services into a community that actually works for patients. Now, as promised, at the top of the podcast, we talked about 5 concrete action items that you can pilot this month to tighten your ED primary care pathways for safer and better care for your patients and to decrease the massive volumes coming to the emergency department and make all our lives better. So let's go through those 5 concrete action plans.
Number 1, redesign your ED to support trusting relationships between your patients and their primary care teams.
I think secondly, explore a virtual first or call first model that could be regionally based.
Number 3, participate in initiatives to educate the public so that they can take care of themselves and know where to go when they need help.
So I think number 4 really builds on that, and that's, empowering patients with their own information, and so ensuring that they know what happened when they were in the emergency room.
And number 5, participate in a new model that's being tried out in your local health system to reimagine what care might look like, whether that's sending doctors out to do home visits, whether it's including peer support workers in the emergency department, whether it's partnering with primary care in a new way. Those models will only get liftoff if the clinicians working in the system are willing to take a risk and participate in them.
And maybe can I put in a number 6? The bonus is going to be to consider engaging with patients and the public around understanding what's working well for them in your ED and what it is that could be better.
Fantastic. So we've got 5 plus a bonus action items that you can take to your departments in the next few weeks. So where does this all leave us? Nearly a decade ago at SMAC in Dublin, we asked if emergency medicine was a failed paradigm. Weingart warned that trying to care for both the critically ill and the system's castaways would burn us out. And Simon Carley countered that adaptability, the willingness to care for anyone, anytime is our superpower. And I think both of them were right. Today's conversation with Tara, Kiran, and Danielle Martin brings that debate full circle. The real paradigm shift isn't narrowing what we do, it's widening who we do it with and how we do it best. Because our current trials and tribulations in our EDs aren't just ED problems. They're a system problem. And many of the solutions live at the interface between emergency medicine and primary care. Thanks so much, Dr. Martin and Dr. Kiran, for your insights and wisdom on the incredibly important topic of how we can make this healthcare system work.
Thanks so much.
Thanks for having us.
Good. And the quote of the month this month is by Paul Batalden. Every system is perfectly designed to get the results it gets.